All right. Let me go ahead and share my project with you. Okay. So I focused on anti-hyperlipidemics and how they affect the cardiovascular system. The therapeutic classes that I wanted to go over, basically, I wanted to just talk about all the classes that are available. Bile acid sequestrants, nicotinic acid, fibric acid agents, cholesterol absorption inhibitors, and statins, which is what I'm going to be focusing on. Bile acid sequestrants, all of these really work in the same way, similar ways. Their focus is to decrease LDL and increase HDL. Some work better alone, and others, most of them, work better in conjunction with other medication. Nicotinic acid, for example, works better with statins and bile acid sequestrants. It's important to let patients know symptoms such as the nice and flush that you get from taking nicotinic acid. Fibric acid work well for decreasing LDL and triglycerides and increasing HDL, and they decrease the production of triglycerides in the liver. Cholesterol absorption inhibitors, they decrease HDL minimally and minimally decrease triglycerides. And statins, of course, is the one I'm going to be focusing on. Pharmacological classes, HMG-CoA reductase inhibitors. They inhibit the production of HMG-CoA reductase and therefore reduce the synthesis of cholesterol, and also slightly increase HDL. Examples are atorvastatin, simvastatin, lovastatin, and rosuvastatin. The obvious indications are lipids, elevated lipids. You also, if you have a history of CAD, angina, myocardial infarction, stroke, and atherosclerosis are all indications for medication such as statins. Pathophys of hyperlipidemia, there's two types, primary and secondary. Primary results from familial or genetically based hyperlipidemia, and then secondary is due to disease processes, along with obesity, alcohol intake, and diet and exercise, or lack of diet exercise. And these are a list of lipoproteins there, along with their levels. We're used to seeing those when we get our labs drawn. And then always talk to patients about modifiable versus non-modifiable risk factors. Atherosclerosis is the buildup of LDL within the endothelial layer of the arteries, which causes an eventual blockage of the arteries due to plaque buildup. So what happens is there's an inflammation, oxidation occurs, inflammation, monocytes come to the area, they attract and become macrophages, which leads to further oxidation and further inflammation, which causes the arterial lumen, as seen here, to inflame and decrease in size, leading to myocardial infarction, angina, and other CV issues. Therapeutic drug goals are obviously to lower LDL levels and HDL levels in the blood. The nursing management focuses on importance of exercise, diet, and fiber intake, as well as weight loss, teaching patients to monitor their blood pressure, medication compliance, as well as following up with your doctor. It's important to know the side effects of the medications such as statins, because there is a lot, including rhabdomyolysis, which is the biggest problem in while taking statin. It also affects liver function, the use of barrier contraception due to the high risk of fetal abnormalities and defects. You also need to let them know the adverse reaction when concurrently using medications such as digoxin and warfarin. The alternative and herbal therapies that we have are many. These are just a few of the most popular ones. Focusing on omega-3 and red yeast rice. I read another article regarding red yeast rice, stating that chemically red yeast rice is identical to lovastatin and works exactly the same way, yet FDA has not approved it. because they say that they cannot determine the active ingredient in it. So that's no surprise. I'll talk more about omega-3, but garlic, obviously they do show decreased LDL level, but the research isn't there. No one wants to pay for research on garlic because it doesn't bring in money. Cultural considerations, health disparities is huge here. You know, where your patients live, what neighborhoods they are surrounded by, the access to fresh markets, access to transportation and good health insurance, education levels, all play a huge part in compliance and, to medication and testing and just monitoring things like the cholesterol levels. Also make sure that they know that you are aware that diet and does have a strong cultural attachment, and that we're not asking them to leave that all behind, but there is a significant amount of you know, work behind leaving certain habits. So make sure that you're making your goals attainable and realistic for your patients. That's basically it for that. This is just cultural considerations as far as what populations are most at risk for cardiovascular disease. The red, obviously, are your CV and according to diseases there. The research evidence paper that I wrote is called Residual Cardiovascular Risk in Patients Who Received Lipid-Lowering Treatments in Real-Life Settings. And the objective was to assess the residual risk of cardiovascular disease after the treatment with statins and other multi-drug use, not statins. And they found that the study that there was always a residual CV risk remaining in about 69% of the patients. That reaching therapeutic goals did decrease cardiovascular risk, but did not remove the risk of CV risks. So the reduction of triglycerides and increase of HDL was the key in the reducing cardiovascular risk, combined with fibrate and statin. The fibrate and statin use was the ideal combination, as well as omega-3, which is the second article that I read. The omega-3 carbolic acid monotherapy in combination with statins was studied, and it established that the benefits of omega-3 CA as monotherapy and in combination with statins. The FDA did approve omega-3 as for lowering triglyceride levels. The statin use alone, still patients can have the CV risk. So the benefits of omega-3 in diet and exercise were ideal in the reduction of triglycerides by 25 to 30%, with the doses there, as you can see, 2 to 3 grams per day of omega-3 in combination with statins were of the most benefit. That's pretty much it. Sorry to speed through things like this, but it's a lot of information. My references, and I could not attach my pamphlet, but you will get it later. Okay, thank you very much.